Thank you for the audience for being here. Beyond VEGF in diabetic retinopathy, that sounds like a future vision. But I just want to give you some thoughts on some present developments in the treatment of DME that may be useful for your daily management of patients. Let's start where we are now. Anti-VEGF treatment in DME is very effective. And I take you to this slide from the Protocol I study from some years ago, which showed something we hadn't expected at the time, but was very key and which we all see in daily practice. That this was based on a kind of PRN scheme where patients were treated based on the outcomes. And the study showed that in the first year, the median number of injections was very high. Basically, patients were treated mostly monthly or very frequently. But then in the years after, the number of injections needed diminished very quickly. And the median number of injections in the second year was already 2 to 3, and in the third year only 2. And that means that half of the patients had 2 or less injections, so an injection every 6 months or less. So where are we now? The annual costs of aflibercept in Europe alone are between 1 and 2 billion euros. That's an enormous amount of money. This is the most expensive drug in Europe. But these drugs, and like ranibizumab, are going off patent. So we got cheap biosimilars, and that will bring the prices down, and we can really cut down on expenditure of costs of ophthalmic care. Of course, industry is looking for new blockbuster drugs to fill this void. And what are the candidates for them? Well, brolucizumab didn't really make it because of inflammation issues. Faricimab, on which I would like to tell you more. And maybe aflibercept 8 milligram. So where could new drugs come from in DME? And where does faricimab come in? Well, the main drivers of DME are hypoxia-induced mediators and inflammation mediators. And of the hypoxia-induced drivers, of course, VEGF is the key one. Angiopoietin-2 is also a main molecule induced by hypoxia, and there are some others. So let's look at angiopoietin-2. What is it? It's a growth factor, and it binds to a receptor on endothelial cells, which you can see here on the left side. But there's another growth factor called angiopoietin-1. And if you take a resting tissue, angiopoietin-1 is the main molecule. It's produced by the parasites, which are the paracellular cells that are attached to the endothelial cells. And angiopoietin-1 binds to Tie2, and that leads to a signal in endothelial cells to take it easy, to become less permeable, quiescent, and stable. In the meantime, the endothelial cells then produce a factor called PDGF, which binds to receptors on the parasites and tells the parasites to be stable, quiescent, and relaxed. So basically, it's a tandem between these two cells that ensures homeostasis in normal vessels. But when a tissue is threatened by the disease, hypoxia, inflammation, etc., this other factor, angiopoietin-2, comes in. And what does it do? It also binds to Tie2, the same receptor, but it doesn't give a signal. So if there's a lot of angiopoietin-2 around, the Tie2 signal is diminished or reduced, endothelial cells get sort of nervous, disturbed, activated, and the situation is set for increased permeability or angiogenesis. This is very interesting. It's beautiful science. But if you look at the bottom of the slide, this is science from 26 years ago. This is something we have known for more than 20 years, exactly this. And if you look at the literature since then, there isn't a lot extra. There isn't a lot more information. So why only in 23 we get a drug that also targets angiopoietin-2? Because that's what faricimab does. Faricimab binds to VEGF on the one hand and to angiopoietin-2 on the other hand. And this is a slide from Roche, which basically shows the same thing. There's no additional information. There's no new signs on angiopoietin 2. That's important. So let's look at the studies that have been done by Roche in DME. Because what you will hear, and have heard a lot over the last year, is that there's a claim of increased durability. Faricimab is presumed to work longer than anti-VEGF agents that we have up to now. But the question is, does the evidence available really show this? So let's look at the study that they did. They compared 6 milligrams of faricimab to 6 milligrams of faricimab in a personalized treatment interval scheme. I will tell you more about that later. And the third arm was aflibercept, and aflibercept was used according to label, which means 5 injections and then injections every 8 weeks. So a fixed regimen, no treat and extend like we would do in daily practice or a PRN kind of scheme like the American studies have done, like Protocol I. So let's look at this personalized treatment interval, which allowed patients to be extended up to 16 weeks. And I want to take you to the slide here on the right upper hand corner, where you can see a kind of table showing how patients were extended to intervals longer than 4 weeks. Well, if central subfield thickness, so an OCT parameter, was stable and visual acuity was stable, the interval was extended. But you can see that the visual acuity could go down like 10 letters and then still the interval was extended. That is not something we would do in daily practice, would we? And if we look at the OCT could increase, the CST could increase up to 20% from the 325, which was the sort of baseline where people were extended. So that goes up to 390, and then still people were maintained on that same interval, meaning that the study sort of looked for an interval where the OCT values could still be much higher than what we would call a good response. So compared to what we do in daily practice, the criteria for this extension were much leaner than we would do in daily practice. So with this approach, in this PTI arm of the study, after 52 weeks, they found about 50% of patients on a 16-week interval, including patients that were planned for a 16-week interval. And if we look after 2 years, there were 62 patients on a 16-week interval and about 80% of the patients on a 12 or 16-week interval. That sounds very impressive, but couldn't we have reached that with aflibercept? We don't know, because there was no arm in the study where aflibercept was used in the same way. And if we go back to the Protocol I data from a long time ago, and this was ranibizumab 0.3 mg, and we know that there's indication from a Dutch study that ranibizumab 0.5 mg works better in DME than 0.3 mg. Look at these figures again of the Protocol I study. In the second year, the median number of injections was 3. So a median number of injections of 3 is an injection every 16 weeks. So 50% of the patient, more than 50% of these patients in this study also had a 16-week interval at 2 years. Nothing different from the outcome of the faricimab study. And now let's go to the primary outcome measure. If you look at a clinical study, you always have to look at the primary outcome. That's the most important thing. Secondary outcomes, chance could play a role. The primary outcome, that's what it's all about. So does adding inhibition of angiopoietin 2 add to the efficacy of the drug compared to anti-VEGF? The answer is no. There was no superiority. Look, the lines on the left are identical. So if there was really a key role of angiopoietin 2, you would expect some synergy at least. It wasn't there. So is there hope for faricimab? Yes, there is some hope, because look at the OCT findings. You see a zigzag pattern with aflibercept. That's not surprising, because we know that there are patients that need an injection every 4 weeks. So they will have an increase in their OCT on an 8-week schedule, as was used in the study. You get a zigzag. But look, the aflibercept, the faricimab arm, where faricimab was used every 8 weeks, you also get a zigzag. So there are patients that need faricimab on a shorter interval than 8 weeks. So it's very similar to aflibercept. But then, so there's differences between patients. That's basically what these zigzag patterns are showing. So I think that faricimab is very valuable as a second-line drug in non-response to anti-VEGF agents. And I think practice will learn us how often that will be helpful and to watch and whether we can really extend earlier or to longer intervals than necessary. Because again, in the second year of treatment with anti-VEGF, the intervals are usually already very long for a large portion of patients, but there's another group that needs frequent injections. So that differential response is not taken account in these industry studies, but we see it in daily practice, and that's very important. So if I put it all together, will faricimab really change our management of DME? Of course, I hope, but there's a big drive to replace existing expiring blockbusters. The science behind this drug is more than 20 years old. The primary outcome shows no superiority. The study design has issues because aflibercept was not used in the same PTI schedule. The secondary outcomes now are the main selling point. And if you look really critically at the data, we don't really have the true evidence. So, and how will it fit in our daily strategies? That's another question. And then, this is an expensive drug. The biosimilars will be much cheaper. We can save billions by being cost-effective. I think this is a responsibility we have as ophthalmologists towards our societies. So, look at cost-effectiveness, and it may be much lower than for biosimilars. Thank you for your attention.
Are there any questions for Professor Schlingerman for this presentation about the new perspective of beyond the pure VEGF family? Okay.
As you said, there's missing data versus aflibercept 8 milligram. Do you think that it will change anything for decision of treatment?
Well, yes, if that PTI scheme had been used for aflibercept in an arm for aflibercept 2, we could have made a real comparison, and that would have brought a signal of superiority out, which of course would have been very interesting, because of course it's possible that faricimab has either advantage in a subset of patients or maybe over all the patients, but it's difficult to figure it out if the comparison was not really just. Yeah.
Hi, thank you. Thank you for the lecture. Since focal DME was also included in the study,
I know.
How can you tell that most of the cases that became dry for a long time were not from the vasogenic, not tractional ones, because most of the diffuse edema was found to be tractional. So
yeah,
how can you tell that it was not focal?
Okay, that's an interesting question. I think that's an interesting question for Roche for a subset analysis, a post hoc analysis. Yeah.
Any other questions from the audience? Okay, we move on to the next presentation by our friend Jennifer Sun from US.